Stan, does it have to be this noisy?
We welcome everyone here.
Just keep the door closed.
We enjoy the pre-meeting conversation too, which has generated ideas for future presentations. So thank you, Dr. Rogers. I hope that we can tap into your knowledge and your experience on that. Thumbs up. I thank you so much. Well, welcome to everybody who is on and who's joining for this month's CMDA meeting. And we're so happy to have you all here for our June 6th meeting. And we have a wonderful agenda with some amazing speakers that have agreed to put together some education for us. And I do see the people from the DR-COG Area Agency on Aging already on. I think Mary and Lauren, thank you for jumping on. And if you'd like, I can go ahead and let you start.
Great. Thank you so much for having us. We're excited to talk with you all. And I think this information should be useful for you and the people that you serve. So my name is Lauren Bell. I'm the program manager with DR-COG's Community Options Program. DR-COG stands for the Denver Regional Council of Governments. And we're an area agency on aging, which serves older adults. And so that would be those over 60 and anyone over 18 with a disability. I also have Mary here with me today for the Centers for People with Disabilities, and I'll let Mary introduce herself.
Hi, my name is Mary. I'm the Nursing Home Transitions Manager for the Center for People with Disabilities. We are an independent living center, and we provide independent living services in 5 counties. Some of those core services involve independent living skills, advocacy, referral, transitions, and peer support. And I think we will be talking to you guys about our transition services.
All right, so I will start us off here. Can everyone see my first slide?
Yep.
Thank you. I'm not used to Zoom as much, so I'm glad it's working. All right, so I'm going to talk about our Community Options Program, which provides options counseling for Medicaid transition services. And Medicaid transition services is a benefit available to people that are living in a skilled nursing facility, a regional center, or an intermediate care facility who are interested in moving to the community. And we'll talk a little bit more about that. But before we do, I want to just give you some background of how this program evolved from the Olmstead Act of 1999. And that act upheld the integration mandate of the Americans with Disabilities Act, making it illegal to isolate and segregate individuals with disabilities from the community. Further, that act requires that governmental entities provide services and supports to individuals with disabilities in the most integrated setting. If the individual can benefit from community placement, the individual does not oppose the transfer, and the community placement would not cause the state to fundamentally alter its programs and services. And number 2 there, the individual does not oppose the transfer, is really where that options counseling conversation is really important, because sometimes people are interested in learning about their options for moving to the community, but they may not always decide that it's a good fit for them. So to say a little bit more about options counseling, what our role is here at DR-COG, we're really the starting point for Medicaid transition services. So we provide a lot of outreach and education surrounding the program. And then when we meet with residents individually, we provide something called options counseling. And that's a person-centered approach to helping individuals gain an understanding of the benefits and limitations of the long-term care services and supports available in the community, and then also the knowledge to access these resources. So really just doing a lot of that education, informing them of the benefits available through Medicaid, like home and community-based services benefits that Mary will talk about, so that they understand the options available to them in the community if they'd like to explore that option. We also empower individuals to make choices that reflect their unique needs, values, and circumstances. So in those conversations, we're always learning what's important to an individual, and it's always really interesting to learn from them what things are important if they were to move to the community. For some folks I've talked to, that's having a space of their own to be able to cook, For others, they may want a roommate, or they may want to move to a certain area where they're connected to their community. So it's really different for everyone, and we like to learn about those options upfront so that we can let their future transition agency know. And with that, we're really the first step to enrolling into targeted case management transition coordination, which is also known as TCM-TC. And that's where the individual will then work with a transition coordination agency who will help them further explore if a transition is a good fit for them, and then what services they would need in the community, and also the big one of helping them to find housing, which could be an apartment, an assisted living facility, or a group home. So they really work closely with them to provide that case management throughout the process. But we are that starting point to gather some information, see if it's something that interests the person. And then if they'd like to explore that option, we help them enroll. And individuals can always disenroll at any time. They can always change their mind. But we do help them with getting started. To talk a little bit about eligibility for the program. As I mentioned, this is a benefit through Medicaid, so they do need to have long-term care Medicaid. And then as long as they're over 18 and living in either a skilled nursing facility, intermediate care facility, or regional center, they do qualify for both options counseling and then potentially to enroll into Medicaid transition services. So that is how the process starts, and I will let Mary take it from there to talk about targeted case management transition coordination.
Thanks, Lauren. As Lauren mentioned, the first step is that options counseling, and then from there, the transition agency receives a referral from Dr.COG or the other options counselors in that county. If you want to move to the next slide. Awesome. Just as Lauren mentioned, TCM-TC stands for Targeted Case Management Transition Coordination, and targeted case management is a benefit available to members transitioning from an institutional setting to a community-based setting. So during this process, we do help them determine if a transition to a community-based setting is possible by performing a community needs assessment and a risk mitigation plan to identify any services or supports that they may need when they are out in the community. If the transition is recommended, then we'll move forward with the services, which would include, comprehensive assessment, community risk assessment, development of transition plans, referral plans, monitoring and following up activities, and options counseling, just as before. So they are not a transition coordination agency, that they are the ones that will make the referral to the transition coordination agency. So there's 4 services in the adult home and community-based services waiver to help support members in the community after transitioning from an institutional setting to a community-based setting, or after a major life event. These include life skills training, which is an individually designed program to maintain the ability of the participant to live as independently as possible in the community. So the life skills trainer will work with the member to come up with goals such as budgeting, or if they need assistance with their Social Security, to complete those. And then also they have home delivered meals, peer mentorship, and then transition setup. So the transition setup involves, making sure that they have everything that they need set when they transition out into the community. So that could be, purchasing furniture or food, getting them set up with different services as well. So what is the role of the transition coordinator? So a lot of times we are the members' advocate. So we are advocating for their preferences regarding community living options and resources. We also help to assist in the creation of the transitions options team, which is that first phase in transition coordination. So We help facilitate meetings throughout the process. As I mentioned before, we complete a lot of community needs assessments and risk assessments. But that's also something that we are periodically reassessing as well. We do develop a transition and risk mitigation plans. So with this, we are basically, responding to the assessed needs or preferences of the member, but we're also identifying risks to the member's health, welfare, and safety, and ways to mitigate those risks before they do move out into the community. Our role also includes coordination of the non-Medicaid services and supports. So as mentioned before, that includes the housing voucher assistance. A lot of times with those housing vouchers, they need a lot of documents like their birth certificate, social security card. So we're helping them with ordering those. We also help with, peak benefit applications such as SNAP or energy assistance programs and adult financial assistance. And then, so as I mentioned, we do coordinate with the discharge planning with the member and their options team, which the options team usually involves a nursing facility staff, the case manager, family if they have family around, the landlord, as well as the community providers to make sure that there will be a successful transition from the nursing facility to the community. We also do a lot of coordinating with the case managers, for transfers between programs, as well as if there's a county to county transfer in the community too. We do help promote a member's self-advocacy throughout the transition process, but also preparing them with skills when out in the community too. And then we provide them with post-discharge services. So that usually includes, check-ins to make sure that they are successful in the community, and then also that the services that are necessary are set up and being delivered. And then just to make sure, we do ensure care by preparing members for disenrollment from transition coordination services. By arranging other community resources as needed to maintain a successful community living.
All right, I'm going to jump back to talk about making a referral to us if you have somebody that you think may be interested in exploring this option. And anyone can make a referral. I always like to point that out. It could be the resident that could reach out to us directly, could be yourselves, a social worker, anyone who's willing to do that on behalf of the resident. We can receive referrals a few ways, and I will get a flyer out that has some of this information also. But we have a phone number. People can call us and make a referral by phone. We do have a fax number and an email that you can send our referral form to. And then there's also the online form, which is my favorite, and our flyer has a QR code that will take you there. And then it just has some questions that we need to start providing the options counseling service, so that we know if somebody has a guardian, then we know to reach out to that person first. So it has some questions like that. These are some different contacts information for our DR-COG's options counseling team. As I mentioned, our phone number is a great way to reach us. There's also more information on this HCPUF website, and then my contact information below. I think you also have our slides, so that has Mary's and Maya's contact information as well. If you have any questions about making a referral or just questions about the program in general, we're happy to answer those. And I don't know if we have any time for questions, but I'm certainly glad to stick around if we do.
A question.
Yeah, go ahead.
So I remember a company doing this a good 8 or 9 years ago. Was that you, or do you have a competing company doing this?
So the transition coordination agencies, that's a great question. There's actually 18 right now in the Denver metro area, and then there are more throughout the state. But for the Denver metro area, that we serve as the options counseling agency. We refer out to 18 different transition agencies. So the Center for People with Disabilities is one of those. And this program was formerly known as Colorado Choice Transitions, and that name still gets a lot of recognition. So you might recognize that as well.
Thank you.
And Dr. Eber had a question in the chat box, a great question. As you know, most of the people on this call are PAs, NPs, or physicians. And so the question is, when do you engage the provider to discuss any issues of safety?
I can answer that one too, Lauren, if you want. So yeah, part of that process when we are kind of assessing the needs, we do reach out to the physician. So the physician actually has to sign off on a form agreeing that this transition is recommended or not. And then usually with this, we are in contact with the physician and the care team at the nursing facility pretty consistently. Like I mentioned before, we're always reassessing the needs for those members. So always getting input from, the people that work closest with the member is important.
Question, please.
Yes, go ahead.
Mr. Bob McCurry, is there anything available in Fremont County in this part of Southern Colorado that is similar to that process?
There is. Let me make a note of that county and I can get that information and send it so it can be shared out with you. Because I don't remember who they call them the local contact agency. That would be the equivalent of DR-COG for that area. And then they should be able to provide options counseling and then referrals to transition agencies. But this program is available throughout the state.
Great, thank you.
Thank you. Yeah, I'd be happy to share whatever you send us to Dr. McCurry and to everybody. And Dr. Ebert has her hand up.
Thank you. I'll make it very quick. Thank you so much for this presentation. So useful. And I know it will benefit so many of our patients. But I often don't know how to kind of engage. I often see the form and I sign it, but sometimes there are some nuances that it would be so helpful to talk through with the transitions team about safety, about coordination of medical care. How would we best do that? Who do we reach out to?
So typically on that form that you do receive, it should have the transition coordinator, their name, and then their contact information. But if not, the best person to reach out to would probably be the social worker of that facility, which I'm guessing most of you guys have the contact information for the social worker. So the social worker will always be on our transitions options team. And that way, then we can get in contact with the physician and talk more about the needs of the member.
Yeah, that's something that I've done quite a bit. And sometimes there are some stumbling blocks there just to make you aware that sometimes that communication is a little bit challenging. And it's important communication. We want all of our patients to succeed in their transitions. So we want to make sure we have our ducks in a row. Thank you so much for your work.
Yeah, thank you for informing us about that.
Appreciate that experience. And Jenny Albertson, please. Jenny, if you're talking, you are on mute.
What is your level of communication with the RAE? Do you facilitate that, or is it expected that the facility does the RAE contact in this process?
So usually with the RAE, so the RAE and transition coordinators, we kind of overlap in a lot of the services that we do offer. So if the member is interested in working with a RAE, then yes, usually the transition coordinator will be the one to initiate that and work with them on that.
Okay, and then one more question, if I may. Is there currently a wait list for meetings with transition coordinators? When I was running a community a few years ago, I think my folks were three to 6 months down the road before they could actually meet with someone.
The great thing is that we no longer have any waiting lists. I know that was the case before I joined the program, but for the last year or more, we've been able to assign folks to TCAs right away. And TCAs are actively able to take a lot of referrals. So you can certainly send those referrals in, and they should hear from our options counseling team within 10 business days of receiving that referral. From there, once we have that options counseling meeting, we assign them to a TCA. Usually it takes about a week. And then the TCA reaches out within 10 business days from the time they're assigned.
Well, thank you for letting us know more about that process. If there are other questions, we're happy to direct them to you, and appreciate all the information in the handout you're going to send us. Okay, well,
Great. Thank you so much for having us. And yes, feel free to send any other additional questions. I will send you that flyer and the information for Fremont County too.
Thank you so much.
Thank you.
And Jenny, since you have already tried out the mic, why don't we let you go ahead and do your update from CHCA? Thanks for joining us.
Thank you. Actually, I was hoping to swap with Chad because I think some of our information might be duplicative today, and I think that he is more apt to speak about some of these things than I am.
Sounds good. Chad, would you like to address us?
Okay, sure. Now I have pressure to make sure that I have that information.
I got you covered if you don't cover it. I'll skip those slides if you do.
Okay, no worries. Hey, I did receive a couple questions, and I wanted to provide some of the answers for that. One of the questions I received was around a facility receiving a citation for doing a resident review for a secured unit, and that was completed without a social worker. So that was cited. And I did want to make sure that everybody knew that the requirements around secured unit placement fall within the state requirements, Chapter 5, Section 23. And so there is a requirement for a designated team, and the team should include the DON or designee, the social services staff member, the administrator or designee, and then another person with mental health social work training who's not a facility staff member. And then it's also mentioned again that the kind of a continued stay review, if you will, should be performed by the evaluation team that was described previously. So there is a requirement for that, and it is in the state rules, Chapter 5, Section 23. Another question that we received was around a facility primary care provider refusing to do regulatory visits on a resident once they've enrolled with hospice, stating that the hospice physician should perform that. And the issue with this practice during the required visits by the physician is that during that required visit, that must be an evaluation and management of the resident's total program of care. So if the hospice physician is focusing specifically on a portion of the resident's program of care, this would not meet that requirement. Unless there's an agreement by the hospice physician to assume the role of evaluating and managing the total program of care, the responsibility still lies with the primary physician. Moving on quickly. Just to let you know that we've received some more guidance around some of the areas of I guess I should say heightened attention from CMS. And a couple of those areas include the nurse staffing. And so some of the new survey approaches in looking at nurse staffing are going to be to review the reported payroll-based data prior to completing a recertification survey. And when we make compliance decisions about that, we're going to be looking at licensed nurse staff 24 hours a day, sufficient nurse staffing at all times, that there's a registered nurse 8 consecutive hours, 7 days a week, and mandatory quarterly submission of staffing information. So these are on a continuum in terms of kind of most subjective to more subjective in terms of our review. If the reporting is not being done, that's pretty much, actually that's to the point with within its objectivity that this is something that CMS may take on themselves at some point in the future, just like the NHSN reporting. If it's not reported, it's an automatic citation. And then as we go through some of those other areas, we have the ability to kind of look at more of the individual circumstances that may be contributing to this information that's being reported and try to better understand that. Another area that CMS has had more conversation with us about is the antipsychotic medication use and erroneous schizophrenia diagnoses. So CMS is doing audits of MDS information, and from those audits, they will be sending alerts to each state agency. And those alerts will be triggers for us so that when we come out with an upcoming survey, that we will be looking at these particular areas if a red flag has been produced. And some of those red flags will include new diagnoses of schizophrenia, changed diagnoses, and then in our review, looking at the lack of documented evaluations or the lack of documented behaviors. And we've had a question about the documented behaviors, and this would be more like, you know, prior to the addition of the medication, that there weren't documented behaviors to justify, you know, the use of the treatment of the symptom of the condition. One other thing that's recently kind of come to our attention: COVID-19 vaccinations for staff will no longer be required. Facilities are required to provide education and make vaccines available. Testing should be completed based upon current CDC guidance. One last thing I'd like to bring to your attention.
Chad,
oh,
Chad,
yes.
This is Craig Gum. Before we get that out there, I just saw a notice last week that even though the feds dropped their the mandatory vaccine, or they told us they did, they haven't signed that off yet, so it's still required at the federal level.
Okay. The guidance that I received said that based upon this anticipated change, that we are no longer going to, in our visits, we will no longer review staff vaccination, and we will not be citing it.
Okay, great.
Yeah. All right, and then again, just one last thing to bring to your attention. You know, with the all of the emergency rules around COVID-19 with respect to the state requirements, Chapter 2, Part 12, with the end of that those emergency rules, there is now the addition of Chapter 12 is now other information. And what we've done here is we've expanded kind of the coverage of infectious diseases under this Part 12. And the section Part 12, infectious disease mitigation and control, requires an infectious disease mitigation, vaccination, and treatment plan, which includes requirements, training, and responsibilities for the infection control officer. So the infection preventionist is now also a part of state rule. And so the answer to many of the questions we've been receiving about this particular issue is, you know, what should the plan consist of and what should it cover? And basically that answer, because it is very broad guidance, the answer to that is it should cover whatever your facility needs it to be. So again, it expands the focus from just COVID-19 to include more infectious diseases. And this should include your emerging infectious diseases. And with this particular plan and the plan that you had developed in your emergency preparedness plan, you should see some similarities. They should be intertwined to that respect with these emerging infectious diseases that might include Zika, Ebola, monkeypox, or just anticipation of maybe the things that have coming down the road that we're not even sure about. But that's what I have for you, and I'll turn this back.
Thank you, Chad, and thank you for all you who are providing the extra resources in the chat box. That's very helpful for the context. Okay, well, why don't we go on? Jenny, would you like to go ahead and present? I appreciate you putting together your comments for us in the slides.
Sure, and I will not go in depth with everything because I know we are on a time crunch. So let me just zip through this and then you'll have the slides for your reference. This is the detail on the removal of the COVID testing and staff vaccination requirements. And I did put that link to the summary with the links for the actual CMS communications in the chat. Just wanted to let you all know that if you go into CMS's publicly accessible deficiency and survey data, you can see how many surveys are actually behind. I know Chad and his crew are working very hard to catch these up, but if you need a list of facilities that are overdue for an annual recertification survey, so you really need to make sure ducks are in a row, that is accessible, and I can help you access that if need be. CDPHE is, of course, keeping up to date on complaints and IJs, which we would expect them to do. This is not a matter of neglect, it's a matter of staffing. And also assisted living surveys, wanted to let you know that those are very much swamped in complaints right now, and their revisits are struggling as well. There's also been a reinstitution of the discretionary denial of payment for new admissions, and I wanted you to have the detail on that communication. So some of that will probably affect providers that are really just dealing with quality of care issues, immediate jeopardy, findings of actual harm. But it'll be an automatic institution of a denial of payment for new admissions for a 15-day window. It's just a shortening of that need to come into compliance. So just so you know, you might have your staff in your building saying, oh, we can't take any Medicare admissions right now or any managed care because we are in denial of payment for new admissions, and this enforcement goes back into effect now. These are the 4 primary focus areas that Chad told us about up at the Quality Summit for investigation surveys. So I don't think any of it is a surprise. The use of psych meds, like Dr. Anneberg just put in the chat on the New York Times article. And then there's that clarification on the sufficient staffing piece that Chad referred to. CDPHE is proposing an increase to license fees. I wanted you to just kind of be aware that this is out in the ether. They're having stakeholder meetings. Their claim for why it's needed is here listed under the title of the slide. And then our position on these issues as CHCA is listed in the green boxes. Essentially, right now, we don't think our members have much of an appetite for a fee increase since we just received our Medicaid reimbursement increase. And it seems a bit circular to put money in and pull money out again, even though we understand that the department has dealt with funding issues. So we're working on trying to find some equitable solution, and thankfully they are involving the association in their process. And this is the description of the Medicaid funding legislation that got put through. Yay, it's done. Everything is signed, and there are some new provider requirements that you'll just want to be cursorily aware of from your standpoint. But this gives you an idea of the incentives that they're providing now for us to be Medicaid providers, and hopefully giving us a better edge on providing higher quality of care for people that are state dependent. Quick summary on respiratory protection program that CDPHE has put out. That's a snapshot of the self-assessment. You'll see a lot of your facilities kind of scrambling to figure out what they need to do, because this has very much been a top line item in education directly from CDPHE's infection control folks. So there's a lot of resources out there. I can put you in touch with any of those that you need, but they're providing webinars pretty routinely about the medical evaluation portion, which I'm sure a lot of you have had a hand in for ensuring people can actually use an N95. And they just have to have a lot of access to be compliant with what's required, access to PPE. And then the last portion, I'm not going to go over, but this just gives you a teaser, and then the rest of the slides go into the detail on what you need to know about your involvement in involuntary discharges. This is not what we were just talking about with the transitions of care. That is a voluntary process. This is situations where someone's care needs have exceeded what we can provide. Something like a hospital transition that then they don't resolve their clinical condition and we can't provide a ventilator, for example, that's considered involuntary. There's a lot of nuance to this in the new regulatory requirements that rolled out last October. And I think that you all were somewhat neglected in presentation of information about this. So I wanted to make sure you had it here and all the references, and the OIG is particularly focused in this area. So I thought it would probably come to your attention sooner rather than later, and you might as well get ahead of it. And then our events and education are at the very tail end. And there you have it.
Amazing. Thank you, Jenny. Always a good resource, your words and your slides. So really appreciate that. And sorry about the time crunch.
No problem. You have it all in the slides.
Appreciate that. And maybe if there are a couple of these that we want a little more detail on, maybe we could bring you back for some discussion on that specific issue. Yeah.
You know, I'm on call for you anytime.
Thank you, Jenny. Our next presenter is Dr. Lee Anneberg. He's going to talk about subclinical hyperthyroidism.
Yeah, thank you very much. I'm going to give, this was the presentation initially. Let's see if I can get to the right one here.
If there's anything I can help you with, Lee, happy to bring up stuff.
I did this earlier before the meeting started. It's funny it's not. So we had Dr. McDermott present in December, and the reason that we asked him to do this is that we had run across some situations that I wanted to, again, talk about, because there's some learning points here. So I'm going to change to a different thing for a second. So give me another. Well, let's see. I'm not sure that.
This is that article that you just posted for us on the schizophrenia diagnoses.
Yeah, just a second. So why I did this earlier about here we go. So in the top portion of this screen is a cut and paste of the Trident lab reports that had come out in the last 3 or 4 years, and it was misleading. And so I reached out to Dr. Karen Anthony, who's the lab pathologist for Trident, and asked her why they had developed this statement. And she sent me 2 articles. One was on hypothyroidism, which was actually the wrong subject. And the second one was a general discussion of symptoms of thyroid diseases, had no lab data information in it. So the PATH department at Trident was putting out these incorrect lab reports for a number of years. And so I reached out to Carrie Levy, who's on the call or was earlier, to Dr. McDermott, and got some information and articles from them that I then shared with Dr. Anthony, and they took it back to their committee and then decided that they would remove the statement. And so in this part, in the middle now of the page, is their most recent amended version. They just have the lab information 0.45 to 5.33, and they took out that narrative portion that was misleading and incorrect. It's really important to see this slide right here, because this is what so much of the confusion was about. See this vertical red line over here on the right side? That was using the value of 4 that was in that report from Trident Labs. And so that would have literally made about 80% of patients having hyperthyroidism, and that's totally wrong. So over on this side, at the big red bar, is the value that Dr. McDermott cites. Now, in Colorado, he says there's 3 major assays that are being used by labs. One has a cutoff of 0.4, one has a cutoff of 0.45, and the other one, he says, has a cutoff of 0.47. And in his talk, he used the 0.45 because that's what apparently they use in the endocrine department at the university. So the 0.1, which is the cutoff for overt hyperthyroidism, is way down here where my cursor's going up and down. Here's the 0.45 with a big red bar. And then way over here to the right is the erroneous number that was cited in the Trident labs. And so having seen that there were a whole lot of people suddenly being treated with methimazole, I started collecting in the facilities where I'm medical director, the number of cases, and there are about 50 that I found. And then I looked back in the lab data that was available, and I inquired from some of the providers what they were in another facility, because some of them transferred in already on methimazole. And we were able to confirm that 2 out of the 50 met the criteria for treatment. And then I started looking at issues of, were they examining the thyroid gland? And that's very rare to find. And so I would encourage people to start thinking about the causes of hyperthyroidism, because some of them are thyroiditis or inflammation of the thyroid gland, and they do not respond to methimazole. So the categories that do respond are multinodular goiter, toxic nodule. That's sort of 2 variations of nodular disease, and they both respond to methimazole, and Graves' disease. And so remember in Dr. McDermott's talk, he has that picture of the bulging eyes that's typical of advanced Graves' disease. So I would encourage you to pay attention to the corrected lab reports that are now in the lab, and that these were the treatment recommendations that he gave. And so we sent out Dr. McDermott's presentation in its entirety, and it's was in the slide or the files that were sent out. I want to make a couple other things that I've noticed, and that is, don't always think of a low TSH as implying that it's suppressed, because some of the patients have a low value for other reasons. They may have pituitary disease. They may have hypothalamic disease. They actually might have intake of something called biotin, which is a vitamin B7 is the so-called version of biotin. And guess what? The assay that's used in the lab most commonly is involving biotin in the assay to measure the TSH. So if the person that you're measuring the lab value on is taking biotin, you get a falsely low TSH reading, because the amount of biotin in their blood leads to an inaccurate TSH reading. And so the 3 things you need to think about in this regard is biotin itself, multiple vitamins, depending on which brand may have biotin in it, or just, quote, supplements that the family's bringing in. So you actually have to look at the label of every product. And if in doubt, stop all of those supplements, all vitamins, everything for about 10 days, and then recheck the TSH. And that will allow time for the biotin to be out of the blood and get a proper TSH reading. Now that's rare, but there are a number of case reports, and it's something that we see not infrequently, where families bring in supplements and vitamins wanting grandma or their mother or father to take them. So just be aware of the biotin conundrum. So the next thing I'd like to emphasize is, please examine your patients, and you need to record vital signs. And that's the reason is tachycardia and irregularity of the pulse, maybe a tip off to atrial fibrillation. So the stethoscope needs to go under the clothing not on top of the clothing. And you need to listen over the apex of the heart. And don't take a peripheral pulse as accurate, because a lot of AFib pulses are inaccurate when measured at the arm. So keep that in mind. So then develop a differential diagnosis. If you think that the TSH is low and it might actually be suppressed, then you need to say, well, what kind of thyroid disease is this? Is this a form that may respond to methimazole, nodular disease, whether it's multinodular or single toxic nodule, or Graves' disease? But if it's Hashimoto's disease or other autoimmune thyroiditis, then they're not going to respond to methimazole. So just blankly saying, oh, low TSH, quote, suppressed TSH, which I encourage you not to jump to that conclusion, but to go through in your note a discussion of what you think the cause of the low TSH is. And then do the appropriate physical examination on every patient, examine the neck by observation and by palpation, and try to get them to swallow if possible. I know demented patients can't do these things on cue, but use your critical thinking skills and document why you're doing this and follow up. Now, the final thing, and I'm very appreciative of Greg Gahm for years saying TSH is the only test you really need. And in fact, that's true. The vast majority of time, TSH gets you started down the path. If there's a need to do follow-up T3, T4, the thing that, and I had a number of phone calls with Dr. McDermott before he had agreed to do the presentation. The T4 measurement that you do is free T4. Remember, females taking hormones, it affects thyroid-binding globulin and a bunch of stuff. So you can get erroneous total T4s in certain circumstances where the free T4 is a better measurement. The thing that Dr. McDermott taught me was that the free T3 is an inaccurate test most of the time. It's too variable. It's such a tiny amount. It's in picograms or whatever, just very tiny amount, that it's generally not reliable. So when you think you need to do a T3, you need to do a total T3, not a free T3. So if you're doing more than just a TSH, then do a free T4 and a total T3. Nodular disease is one of those cases where sometimes you get T3 toxicosis or too much T3 secretion. T4, when it's taken in exogenous into the body or secreted by the thyroid, is converted into active T3 in the tissues. Very rarely is the thyroid gland itself making too much T3. So that's sort of the end of my discussion. All of these things are shared in the documents, and I want to thank you, and I'm open for any questions.
Thanks, Dr. Anneberg. Appreciate your response to that presentation that we had last December about the hyperthyroidism. And if anyone didn't see it or didn't get the slides, they are on the CMDA website, or you can let me know and I'm happy to send it to you. And so Dr. Anneberg kind of taking it the next step and looking at some of those nuances and reviewing some of the key points from that presentation. Appreciate that.
Yeah, in the article that Carrie referred me to by Dr. Tsai was also included in the documents that I sent, and it was a very nice review of subclinical hyperthyroidism, a review of clinical literature, and it was published in 2021 Endocrine Practice. So thank you, Dr. Levy, for referring that one to me.
Thank you, Dr. Levy, too. Yep. And do you have any general guidelines, Dr. Anneberg, on how often to check the TSH? I know it can be different sometimes when you're monitoring something that's more chronic versus something where there's been an acute change? And then are there differences do you see between hypo and hyperthyroidism monitoring?
In Dr. McDermott's presentation, he gave guidelines about the dosing and frequency of testing. So I would refer you back to his discussion. The issue of hypothyroidism, he also briefly mentioned in this last talk, and mentioned that the goal is when they're on replacement for hypothyroidism is a TSH of 4 to 6. And so that's a little different than when you're treating hyperthyroidism, but for replacement of hypothyroidism, that's what he was recommending. So
I think even after that.
I do a lot of chart reviews in all these buildings, and I see when they change time of day of giving the thyroid, the TSH can go way up. And sometimes they'll, not want to wake them up every morning. So we try to do what Greg Gomes told us for years, is once a week thyroid. And sometimes they do that once a week thyroid with food. And then all of a sudden we find the TSH is 40 and we go back to giving it daily. And, it's really weird. You got to try to avoid food, try to avoid drugs that interfere with absorption, give it on an empty stomach if possible, all of those things. So that's, any other questions? That's it for me.
Thank you very much. Appreciate that follow-up and for all those resources. So our final section today is about the CMDA financial summary. This is the business part of today's meeting. If you've gotten enough education and don't want to be part of the business meeting, that we certainly understand. But Travis Neill, our CMDA treasurer, has prepared a summary especially related to the most recent CMDA annual conference. And we'll talk a little bit about the finances and the business part of CMDA today. And Travis, are you ready?
Yes, sorry, Sarah. I was trying to share my screen, but I was having a little bit of an issue. So the gist of the financials, and here, let me try one more time, see if I can get my screen share.
I can pull up the document that you just sent me if you want me to.
Here, I should have it. Yeah, why don't you go ahead and pull that up? My phone. So the highlights of the annual meeting financials, and the main point here is we did not pull in a profit this year, and it's close. We're waiting for one more vendor payment, which will bring us to just about even. The main sort of differences this year were expenses pretty much across the board were higher. That is kind of part and parcel of, I think, our economy and vendors and everyone kind of raising their prices. And then we did spend a little more money on speakers. And so paid more for travel expenses. We had more speakers come from out of state. And that was a very conscious decision to, put together basically the agenda that we felt was the best for the education. And then on the revenue side, we had a decrease in registration revenue. And we did have less overall registers for the conference, but we also did some pretty good deep discounts for group rates. And so the net effect of less people registering and the group rates was about a $10,000 less in registration revenue. And then the net effect of our expenses across the board was about $8,000 more. But to put this in perspective, last year the conference pulled in a profit of $18,000. And just kind of to remind everybody, we are a nonprofit. Our goal is education. So, you know, to that goal, I think the conference did a fantastic job. It was a very good lineup, and you know, the feedback we received was very positive. And so, you know, as we year to year look for, you know, how are we fiscally responsible and what to do with the money we make, it's all about, you know, how can we provide education, and really how can we get more people involved and engaged. And I think that's probably my big message as I kind of cover the financials is, you know, personally speaking, the first time I got involved in CMDA and then in AMDA, it was the first time I really felt like I was part of a community. And then as I began to attend the conferences and the meetings, the net effect of that over the years, you know, as I reflect back on it, is pretty profound in terms of, you know, I think of all the things that I do that are based on the education that I received at these meetings. And so the joke I make often is that I am preaching to the choir with the crowd that's here. And it's the people that aren't here that we need to try to reach. And so, you know, really that's our mission, is to try to spread education and really, reach providers, whether that's in rural communities, but really just asking everybody to talk to your peers about the education that you get at not only our monthly meetings, but also the Geriatric Journal Club, and then the annual conference. And, you know, the actual expense for that conference relative to the education you get, I think you'd be hard pressed to find that kind of value anywhere in the country. So, you know, I think for next year, really would just like to focus on seeing how we can increase participation, because I think what we really wanted to do with the additional speaker fees and paying for their expenses was just bring in a really good lineup. And I don't see that changing year over year. And so, you know, while we will be looking at the expenses, I think it's really about trying to increase the registration revenue piece. And then, you know, we're always open to ideas and ways to reach providers and to, you know, basically spend, you know, what we do have. So we still have a healthy bank account, you know, and especially relative to what we're trying to accomplish. And of course, if anyone has any specific questions on the financials, please, you can send me or Dr. Pallett an email.
Hey, Travis?
Yes.
What is our balance sheet? I mean, this is what you showed us was one point in time this year. What's our overall balance?
So we have a $33,000 bank account balance currently.
Yeah. So it's important for everyone to know that that's been approximately stable for about 20 years. We're not making money as a not-for-profit, and that it took us in the early 90s, we had our first big meeting in Aspen and went in debt, about $5,000 from an expensive dinner. But anyway, after that, after we got caught up, then we stayed in the 20, 30,000, upper 30,000 range. And then Roger Birmingham took over for a while, and then Greg Gom had been treasurer for a while. And so a number of us have shared that, but I think it's really wonderful that we provide education and that we're not making money off of this. We're stable.
Thank you for those comments. Dr. Eber, you have your hand up, your electronic hand.
Yes, I agree. I agree with what Travis and Lee said. I'm trying to lower my hand. It's not working. I'm not lowerable. Okay. And I just wanted to let people know some of the discussions within our board about making our annual conference really accessible financially. So we really gave a lot of thought to how much we would charge people to come to the conference, knowing that we were going to serve breakfast and lunch and coffee. And we really wanted that finances not be a barrier for anybody. And so that's one of the things that obviously affected our balance sheet. But I think that it was the right thing to do because we really want to make it so that anybody can come to the annual conference. And if you ever hear of anyone or you yourself have a question about coming to the conference, don't hesitate to reach out to Dr. Pallett, Travis, myself. You will always be welcome to the annual conference and anything we do. That's the purpose of us being here. And so even though we did not make a profit, I think we put our values right where they should be. So thank you to Travis and Singh.
Thank you for keeping that values and that mission in the forefront, because that's why we're all here. And we're just asking those of you on the call, if you have ideas on how we can increase our reach and get more people involved with CMDA, more people to come to the annual conference, or if you have ideas about programming where you want us to use these CMDA funds, let us know. And we want to try to use them wisely and reach as many people as possible in keeping with the goals of this organization. I certainly appreciate Travis. Thank you for putting those finances together. And if anyone has any more detailed questions about them, please let us know. Thank you all for your comments today. Appreciate you joining the CMDA monthly meeting. Our next board meeting will be in a couple of weeks, and then our next monthly meeting will be the first Tuesday. Oh, no, it won't be. The first Tuesday of the month in July falls with July 4th. So we will see you in August. Thank you so much. We'll see you next time.